This is pulled from our website, as I'm sure if you've been familiarizing yourselves with our website, we've been gradually putting more and more visualization of our data on there to sort of help people understand what what is happening in the state of Hawaii. And frankly, it's very similar to what other states are seeing. I'm on a lot of calls with other colleagues, other state epidemiologists on a weekly, multiple times a week actually, as well as with subject matter experts from the CDC. And we are constantly discussing and sharing experiences and trying to better understand as a whole what is going on and what we need to do. And with regard to the group today and our topic, this slide I hope shows you why it is such an important topic. And really I direct your attention to that last bar, the 60+ years. This is essentially a graph showing you the age groups in 20-year age groups really. In the state of Hawaii, those that are by case numbers essentially, and so the case numbers on the y-axis and the x-axis showing the age groups, and the orange shows you how much the proportion that are really representing the those requiring hospitalizations. So it's really rather striking that in the pediatric age group, we're really seeing not much disease as a whole, and at least in the state of Hawaii, knock on wood, we've not seen a pediatric case hospitalized. Whereas as you get older, you see a greater and greater percentage of the cases that are requiring hospitalization, and really the bulk really is in the older age groups. So that's why this topic today is so important, and the people you take care of in the long-term care facilities. I mean, this is the crux of what we need to do now, focus on. And I will tell you that it is one of the things that I've been advising our state leadership, our health director, regarding the question of when do we start to reopen. One of my answers is that we need to make sure our long-term care facilities are appropriately resourced and prepared to be able to deal with potential patients in the future. And let me also be clear that while we are dealing with this current wave right now, it is the current wave, and I and many of my colleagues in the nation all understand and agree, as well as CDC experts, that unfortunately we will likely see future waves. When those occur, we really cannot predict, but I think I know we are all on the same page in that all of us have to prepare accordingly. And the real answer to how we are able to manage in the future is the fact that we need to make sure certain controls are in place, and that our healthcare system and our long-term care system is appropriately strengthened to be able to handle potential new cases that are reintroduced in the future. So next slide. So here's where I'm going to hand off to Katie. Ms. Cook has been with us for several years now and has been very ably, I'm really proud of the fact that she has led our team so fearlessly on the infection control front. If you've not had the pleasure of talking to her, then I'm quite surprised actually, because I know she's been leading weekly calls with all the infection preventionists of the hospitals from the get-go, from the start of all this, and then she added weekly calls with infection preventionists from the long-term care facilities. So I hope if you are listening to this and you are not aware of that, I hope you do touch base, and if you are thinking you're not connected, please do reach out to us to make sure, but I'm pretty certain at this point she's reached out to all of you and vice versa, and we have increased her team from here I do a head nod to the School of Medicine, the residency programs, because we have, and the School of Nursing, by the way, as well as our own public health nursing program, because we pulled from all of those to increase the team here to support Katie. So Katie, why don't you go ahead?
Yeah, thanks, Dr. Park. I'll just start by saying, if you haven't heard from me personally yet, you will have probably already heard from one of the volunteers that Dr. Park just mentioned. The nursing students are making individual calls to each of our licensed long-term care facilities. So I encourage your staff, they're trying to reach the point of contact for infection control or the director of nursing to have a one-on-one conversation regarding these topics. So I encourage your staff to answer those calls and engage with our team of volunteers to address your infection control questions. I don't need to tell anyone here about the congregate nature of long-term care facilities, and also the populations that you serve are particularly vulnerable with chronic underlying medical conditions. Now is the time to reinforce adherence to infection prevention and control basics, especially appropriate hand hygiene and selection and use of PPE. If you haven't already, we're asking everyone to please implement universal masking, at least in all patient care areas. And you may have to explore options for reuse of masks or extended use of masks in order to make your PPE work to implement universal masking in all patient care areas. Appropriate PPE for suspected or confirmed COVID-19 residents means a face mask, a gown, gloves, and eye protection. N95s are needed if your staff will be performing aerosol generating procedures. However, keep in mind, N95s require fit testing and should be used in the context of a comprehensive respiratory protection program. If your staff are not already fit tested and prepared to use N95s, at this point, it's best to focus your efforts on the appropriate use of surgical face masks. I want to encourage everyone to pay particular attention to donning and doffing procedures in their facilities, especially doffing. We know one of the highest risks for healthcare workers is of self-infection during doffing and not adhering to meticulous hand hygiene after doffing. I know that everyone's been forced to get a little bit creative with PPE, but that doesn't mean that we shouldn't pay attention to doffing appropriately. And last, make sure your staff has PPE available where they'll need it. And so this means having your isolation cart or whatever you use for an isolation cart outside of every resident's room, and also a trash can inside the resident's room so they can doff and discard of their PPE appropriately. Next slide, please. So staffing. Healthcare workers and your staff are one of the most likely introductions of COVID-19 into your facility. Start by reinforcing your sick leave policies. Remind your healthcare providers and all staff not to report to work while ill. However, on the facility end, you should also be screening every single person who enters the building prior to every shift as kind of an extra layer in case staff still try to report to work while ill. Make sure you screen them prior to the start of every shift. Screening means actively taking their temperature and documenting the absence of other respiratory symptoms. Anyone symptomatic should be sent home immediately. Additionally, encourage staff to practice social distancing from each other while at work. Encourage them to take breaks outside, for example, rather than gathering in small break rooms. So far, many of the cases among healthcare workers that we've seen in the state have been from coworker transmission, so this is really important at this time. Additionally, don't forget about consultants or other outside staff, such as imaging staff that go between multiple facilities. These folks could pose a huge risk for introducing COVID-19 to your facility, so make sure you include them in all your staff screening protocols. Additionally, identify healthcare workers within your facility who might work at multiple facilities, and understand that if these healthcare workers are exposed to COVID-19 in another facility that they work at, they will be restricted from work in all healthcare facilities, including your own. So you should have a contingency plan in case your staffing is reduced by the amount of staff you have that work in multiple facilities. So even if your facility doesn't have any cases, if another facility does, that could impact your staffing if your staff work at multiple facilities.
That's why. Okay. I don't even get to
Next slide, please. I don't have too much to say about environmental services, but of course we never want to forget these key players in infection control. This virus isn't particularly difficult to kill. It's not like a spore-forming virus like C. diff or norovirus. EPA did put out a list N as in Nancy. You can find easily on the internet. So double check that your UPS staff are using a registered disinfectant that is on this list. They probably are. Most of the normal disinfectants are on this list, but it's a great idea to double check. And while you're at it, ensure that you're using the disinfectant appropriately, including for the recommended contact time. Additionally, reinforce cleaning of any high-touch surfaces or shared resident care equipment. Next slide, please. Same with staffing, but any visitor that enters your facility poses a risk for introduction into the facility. So if you haven't already, restrict all visitation except for certain compassionate care situations as outlined in the CMS guidance. If you haven't already, communicate with your residents and their families about your expectations. Send letters or emails advising them that no visitors will be allowed. Next slide, please. Please actively monitor all residents at least daily, but preferably more frequently for at least fever and respiratory symptoms. Keep detailed documentation of day-to-day vital signs so you can notice any subtle changes in your residents. Ideally, have vitals equipment dedicated to each room. If this is not possible, at least cohort the equipment to one ward and thoroughly disinfect between each patient. As you collect this information, have a low threshold for testing for COVID-19. Next slide, please. Make a plan to immediately isolate any symptomatic residents. Ideally, this would be in a single room and place them on contact and droplet precautions. Remember, for every patient that you place on these precautions, you'll need an isolation cart and a trash can, so you may need a few times more than what you currently have. Ideally, designate an entire unit to clear and be ready to accept COVID patients. Alternatively, you can consider setting aside one hallway. If neither of these are feasible in your facility, at least designate a few rooms at the end of a hallway for patients that are suspected of having COVID-19. We know that moving patients in the long-term care setting is extremely challenging, even in normal times. You may face a situation where you get a lab result, for example, at 6:30 in the evening, and you need to immediately cohort a handful of residents. Make a plan to move about 3 to 5 patients a day at 4 p.m. or later. And don't forget, where will you keep their belongings? Questions like this, try to think about and make a plan now. Make sure housekeeping staff is also available to deep clean rooms for rapid room turnover. As you embark on these measures of moving residents and isolating symptomatic residents, it's a good idea to have a communications plan ready. Likely the actions that you'll be taking that I just mentioned will raise a lot of questions among residents and their families. We strongly encourage you to have your plan ready now that you can deploy immediately in an emergency situation. Transparent communication between your residents and their families will help maintain trust. Additionally, there's no need to immediately transfer a resident to a hospital unless they require a higher level of care than you can provide. And just a friendly reminder to ensure that you notify the receiving hospital as well as our EMS partners if you're asking them to transport a suspected COVID-19 case resident. Next slide, please. We've gotten a lot of questions from our long-term care facilities regarding accepting transfers or new residents into their facility. So we've attempted to lay out some guidance for you all, and I'll cover it here. You should accept any residents you would normally accept if they're not under suspicion for COVID-19. If a patient is was tested for COVID-19 but was negative, but still has signs and symptoms of respiratory illness, it's okay to accept them, but keep them on droplet precautions as you would for any other viral respiratory disease such as flu. One negative test for COVID-19 doesn't mean that all precautions should be lifted. You may accept patients who have tested positive for COVID-19 if your facility is capable to adhering to the strict contact and droplet precautions that we've just outlined. If your facility is not capable of adhering to these precautions, begin preparing now. In the meantime, you must wait. If you're not ready to accept patients on strict contact or droplet precautions, you must wait until transmission-based precautions are discontinued. We have this guidance outlined in the medical advisories that Dr. Park sends out every week, but I'll summarize them here. So they can be discontinued either 7 days after illness onset or 72 hours after resolution of fever without the use of fever-reducing medication and improvement in respiratory symptoms. Whichever of those two criteria is longer. So either the 7 days or 72 hours, whichever is longer. And if you're having a hard time remembering that, refer to the medical advisories. I think it was number 6, but I'm not positive. There's been a lot. And just a final reminder about testing. One negative test is not sufficient to discontinue transmission-based precautions. There is some guidance on the CDC's website for a test-based strategy that you may choose to implement in your facility. However, they should also meet this symptom-based criteria as well. Next slide, please. When to notify us. So as usual, follow the normal reporting requirements for influenza-like illness, which is laid out on our website, but it's basically 3 or more cases in 1 unit or wing in a period of 48 to 72 hours. That's our normal ILI reporting criteria that I think you're all familiar with. Please report to us a single case of lab confirmed COVID-19 in any staff or resident in your facility. And please also report to us if you have a strong suspicion of COVID-19 in any staff or resident. Know that these people are a high priority for expedited testing at the state lab, and we might be able to help you arrange that. To report any of the above criteria, call the number that's listed on this slide here. It's our normal disease reporting line, 586-4586. Next slide, please. For any positive case that's reported to us, we require the submission of a completed PUI form, which we are also calling the case report form. I have a screenshot on this slide of where you can find this case report form on our website. It's that highlighted hyperlink just below that photo. So that's where you can access the case report form, and we will ask for a completed form for any positive that's reported to us. Next slide. For the investigation, we'll also require you to send us a line list with a row for any resident or staff who are ill or who are being tested, so confirmed or suspect COVID-19 cases, similarly to what we do for flu outbreaks. We'll ask for an updated line list at a minimum of every day. Minimum elements that the line list should include are name, date of birth, room number / bed number, so trying to get at the location within the facility, date of illness onset, date of specimen collection, result of testing if it's known yet, hospitalization status, if the family has already been contacted, and then eventually we'll fill in the outcome of the case. We may ask for additional data elements as the investigation goes on, and then just know ahead of time, we will ask for your assistance in contact tracing. So we will need to know any staff or residents who may have been in contact with the index case. So make sure you're ready in your facilities and you're able to provide us with lists of contacts that we can then follow up with. Next slide. Some of the information provided in this presentation came from Canterbury Rehab Hospital in Richmond, Virginia, and the information was sent to me by Dr. Wen, so thank you for that. We borrowed our transfer guidance from the Chicago Department of Health, and actually many other jurisdictions across the country have similar transfer guidance. And I also pulled information from the recent MMWRs. Next slide, please. This is my contact information. So my phone number is 587-6581, and there's my email address. Send your non-emergency infection control related questions to me. And then the disease reporting line is also listed there, as well as the fax number, 586-4595, to send the PUI form and the line list if or when we require it. That's all the information that I have, but we would love to take questions now.
Yeah, so this is Dr. Park again, and just I think you'll recognize as Katie was going through all of the guidance, It aligns with what CDC and other jurisdictions are also advising, and essentially it's a united front across the nation. It is to stress the importance of universal precautions, not universal testing. So that is really important, because testing is not going to change your actions. What we recommend and require of everyone is expected, especially if we're going to get out of this essentially and continue through the next waves that are surely going to be coming. So again, really, really important to stress that everyone needs to think about how to implement, if you've not already implemented, universal precautions, documentation of how those precautions have been implemented, documentation with regard to patient and healthcare staff movement. These things are extremely critical. The PPE supply chain is having its fits and starts, shall we say. The state has received a supply from this Strategic National Stockpile. The Healthcare Association of Hawaii has been distributing upon request, but it's a finite supply. So there are things that we all need to consider in terms of how to conserve that supply. So with that, I'm going to end here and just open it up for questions, because I think, and we deliberately wanted to keep our side short because we recognize there are probably a lot of questions.
Dr. Park, the questions are being written in the chat box. Do you have access to that?
Let me see if I can. All right. Shall I just work backwards, or how does this work? Okay. All right. I see, let's see. It looks like, from my impression, that each facility will have each policy regarding accepting patients from acute care who got better from COVID and transitioning to SNF. I'm wondering how much minimum tests they need to be negative, or will be facility specific. Katie, you want to take that first?
Sure. So I'll reiterate, we're trying to move and not really focus on a test-based strategy. I think everyone out there is well aware with the challenges of tests, sometimes a long turnaround time, sometimes a false negative. We really don't want to put all of our eggs in that one test basket. The guidance that I went over, if someone has tested positive for COVID-19 and they're well enough to be discharged from an acute care hospital, we really want to make sure that transition is able to happen, because we want to keep our acute care hospital beds free for people that require that level of care. So long-term care facilities should accept these people if they're able to adhere to the precautions that we covered throughout the presentation, the strict contact and droplet precautions. If they're not able, they should follow the strategy that we outlined for discontinuation of transmission-based precautions, which is really based on resolution of symptoms. Prepare now to be able to accept patients that are COVID positive and still require strict contact and droplet precautions. Don't focus too much on the negative tests. Certainly one would not be sufficient, and we'll kind of fall back on that resolution of symptom guidance.
Regarding the issue around testing, I just want to comment, if you're not already aware, but there have already been papers demonstrating the shedding of viral material for quite some time after someone has had illness. And that's actually a huge question that is being discussed right now with CDC experts among state epidemiologists. We've all noticed persons, for whatever reason, someone did a retest somewhere down the line, or my colleague in Nebraska, notably early on when they were dealing with the repatriated folks from Wuhan, and it had to adhere to strict testing based sort of guidelines for isolation, because it was under the federal government quarantine orders and such. They noticed early on, and we've all been noticing this, that persons could be shedding even 40 days after an initial onset. I was just emailing with my colleague in Massachusetts the other day, and they noticed an individual that was positive 6-7 weeks out from initial illness onset. What it basically demonstrates is that we all recognize, and any infectious disease physician will tell you, as I am, that with any kind of pathogen, there is, once you've resolved, you're most likely shedding material, which is not necessarily infectious. So the big question then begs, how long is someone actually infectious? And we've all seen instances, when I say we, I'm talking about other states, we've all seen instances where people have long recovered, and yet, you know, somewhere down the line they got tested and they see viral material. We have to remember this is a molecular test that is exquisitely sensitive, although not without faults. So there can be false negatives. And so that's why a lot of us feel that, you know, testing alone is not enough. You need to really consider the context of that testing. It's really critical. It's like any other disease. You have to just consider the epidemiology and the clinical presentation. Granted, there are cases now we recognize that could be pre-symptomatic or asymptomatic, but in this particular population, most likely these patients are going to have some sort of symptom. And really, again, pushing the most all-important sort of holy grail in infection control, universal precautions, that is going to make the difference here. It's not going to be the testing. Kamal, the screen suddenly shifted, so I can't seem to see the chats.
I can read a few questions to you then.
Sure, thank you.
Regarding mask use in all patient care areas with no positive cases, since we are scarce in PPE, are cloth masks all right?
So what we've been saying and what CDC has been saying is that cloth masks are okay as long as you are not engaged in some sort of critical patient care or close patient care. So if you are, you know, charting, if you're walking through the halls, if you're doing something, you're maintaining a certain amount of distance from the patient, you're just noting something in the room, moving something around, the cloth masks are fine. It's really when you have to engage in direct patient care, where for, you know, the care of the patient, for the care of the healthcare worker, that it is recommended by CDC, then you adhere to the recommended PPE guidance. But for all other sort of your receptionists, various other folks, cloth mask is fine. Remember that the whole purpose of the mask, really, in sort of the non-patient care setting, is really to protect everyone else from the wearer. You know, your mask protects me. It's not your mask protects yourself. So keep that in mind, and then hopefully that helps clarify some of the issues around masks.
Thank you. The next question is, if there are going to be waves of COVID-19 and if there's no vaccine on the horizon, when do you anticipate that facilities can resume having regular visitors and communal activities?
So, you know, that's a loaded question, because I will tell you, as an infectious disease physician, and by the way, you know, I hear so many people putting their opinions forward, and I would always caution everyone, just like I caution students that I mentor and others about the gazillion papers I see published out there. You need to know who it is that's speaking with you in terms of what their qualifications are. What, you know, how are they supremely qualified to talk to you? And I would tell you, I'm an infectious disease physician. I'm board certified. I've worked with CDC at CDC. I worked the first SARS response. I've been through the 2009, led us through the 2009 H1N1 response. So, you know, I think that's really important to understand. So, as an infectious disease specialist and someone who's worked long on infection control issues, and actually have spoken with some of the other infection control, infectious disease physicians in the state, a lot of us have always rued the visitor policies that we see. I'm kind of chuckling ruefully right now, because we've always rued the visitor policies we see in our hospitals and long-term care facilities, as we've seen our facilities all move towards this sort of embracing family, and it's Hawaii. I totally get it, and that, you know, you don't want your patients and that you care for to feel isolated and such. But I will be honest and say a lot of us in the infection control / infectious disease realm have always been a bit nervous about the visitor policies that we see here. And so I would actually argue that some of what we're recommending now from our perspective is kind of long overdue to prevent infectious disease spread. But I do think there can be some negotiation in terms of a happy medium. So you know, something to consider in that moving forward, we're in a new normal and potentially in a normal that we should have been in to begin with. As we consider how to protect our patients, granted, how to let them have a pleasant, you know, sort of a pleasant life, especially if it's end of life care and things like this. I totally get that. But it must be balanced against controlling for the spread of infectious diseases. And it's not just about COVID-19. It is just as much about other respiratory diseases, flu, I'm sure you're all familiar with, parainfluenza, adenovirus, all these other sort of respiratory pathogens that can just be just as equally deadly for this population, as well as C. diff, norovirus, other kinds of pathogens. So something to consider.
Thank you, Dr. Park. The next question is about whether the PowerPoint will be made available. Yes, this presentation will be videotaped and put on our website. Next question is, what about residential programs for substance abuse? I assume you recommend the same thing?
That's an interesting area in that to a certain extent, yes, I would say if it's a congregate home setting, but the population may not be quite the same risk population. So it'd probably have to be looked at on a case-by-case basis, to be honest. You know, our focus is really the high risk, again, pointing back to the first, I think it was the third slide, and showing you, you know, we're seeing the same thing here in Hawaii as we are seeing across the nation and globally, in that it is our older persons in the population. And while that slide didn't get into the sort of the underlying conditions, we are also seeing persons with underlying conditions as the high risk. Immunocompromised and various other diabetes, renal issues, you know, so those are the population that we tend to focus on. But in terms of congregate home setting, that is something also to consider, because obviously the risk is the closer people are living together, the more likely spread will occur, and uncontrollable spread can occur if there are not controls in place.
Thank you. Next question is, when we have a patient we are trying to rule out, do we move them to an isolation room prior to obtaining the sample, or only if a sample comes back positive? Also, move the patient to the isolation room or wing, what do we do with their roommate who we assume must have been exposed?
I'm going to hand it to Katie because I've been talking too much.
Yeah, sure. Don't hesitate to move that resident to the isolation room. This should, again, not to harp on the testing too much, but the move to isolation and also the move to discontinue isolation shouldn't really be based on testing alone. Testing is an important tool that's part of our toolbox. Yeah, don't wait. Depending on where the specimen was tested, we don't know what the turnaround time, you know, looks like. So go ahead and just get started right away, isolating the patient. Regarding the roommate, so I would say at that point, the kind of index patient or resident, if we're considering them a suspect case, then we would consider the roommate a close contact. And what we're doing for all of our investigations is asking close contacts to self-quarantine for 14 days since their last exposure. So I would say, you know, while you're trying to figure out what to do, I would consider the roommate a close contact. And I also think droplet precautions would be appropriate for these close contacts, just as we would do with people in the community. Ask them to self-quarantine for 14 days from their last exposure.
Yep.
Okay, thank you. Next question is, as a follow-up, have we had any patients transition to SNF from acute? I assume that means here in Hawaii.
None that I know of.
Yeah, I don't think we've heard of any as yet.
Okay, great. Next question. Kupuna Kukua has been providing donated cloth masks as well as hand sanitizer, 80% alcohol, to selected long-term care facilities that have reached out. Is there a need for those items on a broader scale on Oahu, and do you have an estimate of needs?
We don't have that visibility. I think there are folks at the Hawaii Emergency Management Agency that are attempting to work with the Healthcare Association of Hawaii, HAH, to get more visibility on that. So I'm going to defer to them, but I would expect that most likely, because anecdotally we've definitely heard from facilities that they're short on masks.
Yeah, I agree. And also anecdotally from a few of you, this could be a great way to improve your staff morale, connecting with the community too. I love that the community is getting involved and everyone wants to help, especially for the staff that are not directly involved in patient care and they're free to use the kind of homemade donated cloth masks. This is also a great way to avoid them kind of dipping into the surgical mask supply that you need to hold closely for the actual patient care.
Yeah. Right. Yeah, I'd echo the fact that there are a ton of people out there in our community. If you think about it, everyone it's a shelter in home. People are not in the workplace. I mean, they have a lot of idle time. There are a lot of people thinking and wanting to help. Why not use those energies to help all of us? And and I agree with Katie, the morale, I think, would be much improved by allowing for some of these cloth masks to be used, and it really shows a good partnership with the community.
Okay, thank you. The next question is, what do senior living communities, not nursing facilities, need to do that isn't already being done? I think this is referring to the senior retirement communities where people are sort of independent in their own apartments, so they can come and go, but they're still in a communal setting.
I mean, I think we can go down the list of kind of congregate living like communities and settings. There's a wide spectrum, everything from fairly high level acuity skilled nursing facilities with high proportion of patients on ventilators, all the way down to these kind of senior living communities where people don't require a lot of nursing care, and kind of like what Dr. Park mentioned before, looking at the patient or resident population and their kind of underlying health conditions is really important. We're of course concerned about any kind of group or communal living situation because of the high, the ease of spread kind of among those communities. But I think taking into consideration if these people aren't really requiring that daily, like hands-on close contact care with healthcare workers, they're probably at a little bit lower risk from infection with COVID-19.
I think the bottom line is, again, no matter what kind of facility we're talking about, it is about looking at your facility and thinking about how can you improve your infection control there. And some of that also means directly supporting your infection control team to make sure they're appropriately staffed and resourced, that they have access to training. And as I mentioned, Katie's been holding weekly calls with all the infection preventionists. So if your infection preventionist or your team is not hooked into those calls, please make sure that they do. And Katie's provided her contact information so you can contact her directly regarding those.
Thank you. Do you have any recommendation for hospice? If hospice patients at home are infected with COVID, would you recommend to have them stay home even though it can increase risk of infection among family? Or should they be transferred to nursing homes that can handle COVID cases, assuming that the patient does not want to be transferred to the hospital?
I think that also has to be assessed on a case-by-case basis because it depends on the type of home situation, who's in the home, are they able to practice good infection control, and balanced against, the end of care situation for the individual. So it is on a case-by-case situation. It is why, we want to make sure you all know how to reach out to us so that we can talk through those situations with you.
Thank you. The next question is, a lot of my patients with pneumonia in geriatrics are asymptomatic, with no fever, cough, and chills. They present in atypical ways. I wonder, how do we differentiate them from COVID cases? Do you have any idea how the elderly present? Any data, or do they just present with shortness of breath or with sudden deterioration?
Yeah, that's a great question, and we've not seen any data that specifically segregates out that population yet. I'm sure it's coming. We are certainly interested in looking at our data, but again, we have small numbers, small n compared with a place like New York City. So we're anxious to see what our partners come out with. Anecdotally, we've seen it run the gamut. We've seen mild symptoms, but we've also seen, actually, I think we've seen more having severe symptoms, definitely the shortness of breath. I think I would tell you the same thing I'm always telling people when they ask me about diagnosing flu. There's absolutely no way to know the difference based on clinical presentation. I'm not saying that to advocate testing per se, but again, going back to the fact that it doesn't change that universal precautions are absolutely critical. It doesn't change, by the way, that if we identify a patient as being, or a healthcare worker as being a high-risk close contact of a confirmed case, testing, you can test as much as you want, but that person must still stay in 14 days of quarantine. That testing result will not change anything on that.
Okay, thank you. There aren't any other questions on the screen. I just want to ask the audience one more time. If you have questions, please type them into the chat box. In the meantime, I do have one announcement to make. We do have a nursing home, a long-term care echo series, which is going to start, I believe, today at 2 p.m. I think today is going to be donning and doffing of PPE correctly. And then there are several topics that are to follow. So I think most of the people who are on the email list for our grand rounds will have received those. But if not, if you need to be put on the list, please give your information in the chat box and our staff will make sure you're informed about it.
Can I jump in with, because your comments on donning and doffing remind me of a few other pointers that I'd like to share with folks.
Sure.
Based on conversations, again, I'm on these conversations with my colleagues around the nation. We share experiences, and I remember very clearly my Washington State colleague, his name is Scott, he shared with the group that one of the, he and his team went into one of the long-term care facilities in Washington State, which I'm sure everyone is so well aware of their issues by now. And they noticed that in assessing donning and doffing by the healthcare workers, that they were contaminating themselves on doffing. They thought they were doing okay. So the situation, I should back up a little, the story was that there was a couple cases identified in that facility. They immediately acted to put in all the infection control measures in place, cohort the patients, etc., everything. And yet, despite putting all those things in place and doing all the right things, they were persisting in seeing this steady trickle of cases, and it was incredibly perplexing. And so when my colleague and his team went out to help assess the situation, they found, as they observed, that what was happening was that some of the healthcare workers, in doffing their PPE, and Katie talked about this in our talk, were actually contaminating themselves and their environment as they doffed the PPE. So I can't stress enough, again, emphasize enough how important it is to make sure that everyone, it's not a simple matter of, oh yeah, put on the mask, put on the gown, whatever, and take it off. There is a strict protocol, and it is important that everyone gets a refresher if they've not had one recently, and in how to don, but especially doff that PPE to prevent contamination and prevent illness, whether it's in the patients or other healthcare workers. The other thing I would comment to, so then I would say then that in doffing, it might be a good idea for each person, if possible, to be watched by someone else. Kind of similar, harkening back to when we were talking about Ebola preparedness, if you will. We talked about having a buddy. it's not a bad idea for this and any other situation, especially if you have a situation in your healthcare facility or other facility, to buddy up, to have that buddy system, or have that as a sort of a cushion, if you will, to make sure that you're not seeing, that's not how the disease is spreading, whether it's COVID-19 or flu or anything else. One last thing, as I'll comment, is again, from my Washington State colleague, he had commented that one of the facilities, their facilities had run out of gowns. And so they thought, well, fine, we'll use rain ponchos. They thought that that would be a great sort of, fallback. And unfortunately, I don't know if you've ever tried to take a rain poncho off, but I think if you think about it in your mind, it's incredibly difficult to take off a rain poncho without contaminating yourself. So as Scott put it, he put a stop to that immediately, and they made sure to try and support that facility with appropriate gowns, and try to look for other means to try to limit having to use the gowns so much, as a way to conserve the gowns as well. So two anecdotes I wanted to share with you that I think are especially critical, and hopefully something we can all learn from.
Thank you very much. We have a couple more questions that popped up.
Mm-hmm.
We're frequently testing for influenza and then reflexing to COVID-19 testing if flu PCR is negative. Mm-hmm. Given the decline in influenza incidence, should we still test for flu first?
So flu is still around, but albeit it has gone down. And I think you do need to think about your clinical suspicion. I will tell you that we have started talking about, because we recognize as flu activity goes down, it is the state of Hawaii, which means that we do see flu year round, but we also recognize at a certain point, and we may have reached it, where flu activity does start to decrease, and we have been noticing that. So it really, I defer to your clinical judgment, but on our side of it, I will say that we're discussing on the sentinel surveillance whether actually we might start looking at COVID negative tests and reflex them to respiratory pathogen panels or flu testing, just so that we don't lose visibility of flu. So I know that's not an exact answer, but I would say that it really, again, goes back to what is the clinical history, what is the epi history, and putting that together with then making the decision regarding testing. And then the final note is, do have a low threshold for testing for COVID-19, because we do know there is local transmission, in all the islands now, except for Lanai, which hopefully stays that way. But all the islands have seen some amount of COVID-19. So it is reasonable, especially with your high-risk population, to have a low threshold for testing in an individual who is especially medically frail, so just considering that.
Okay. And then the next question is, can you clarify the sensitivity for the test?
That's also a loaded question, and I say loaded because it is reportedly in the high 90s for sensitivity and specificity, but anyone who understands sensitivity and specificity of tests and prevalence would understand immediately that prevalence of the disease also can dictate how much false positive and false negatives you might see. For now, we are taking all positive reports as if it is true, but we have to also recognize that there are probably instances that we are unable at this time to distinguish where that positive might not actually be a positive. But again, that's where we need to really assess the clinical and epi background. On the other side of it, negatives, not saying necessarily that they're false negatives, but it could just be that someone is tested too early because their exposure period, their exposure was too early relative to the test, or whatever reason, their body is still, maybe they only had a small inoculum, and so it just takes longer for the virus to replicate to a certain amount to be detectable. This is, by the way, the variability in incubation periods. So we have seen instances where people have been tested and they're negative, and then they get tested down the line when they, usually the scenario is they were tested just because there was some concern and the person didn't really have symptoms. And then they develop symptoms some days later and then get tested and then they're positive. So we're seeing those instances as well. So again, stressing the importance of considering the whole picture, as with any disease, and thinking about, you know, when it is appropriate to test. I think the other thing to consider is that, what are you going to do with the answer? Is it going to change what you're going to do? Is it going to necessitate some sort of public health or medical action? Because that's why you test, really. If it's not going to change what you're already going to do, in that, you know, infection control precautions need to be in place, someone needs to stay in quarantine, you know, medical care won't change, then really have to consider, is it really worth testing? I think many of you have worked with us in terms of, in the past with, for example, flu outbreaks. And recall that we don't necessarily request that you test every single person that you identify. We will have the initial few that might be positive, and then we start working with you in terms of cohorting people and especially, again, implementing infection control measures, strict infection control measures, in order to control the outbreak, because that really is, at the end of the game, at the end of this game, that's really the deciding sort of objective, is how do we stop the outbreak? And testing is not does not stop the outbreak. The universal precautions stop the outbreak.
Thank you, Dr. Park. If staff have confirmed COVID, have symptoms, are treated, and then the recheck test is negative, when can they go back to work?
Again, I want us to move away from this idea of kind of one negative test for clearance. So if your staff have COVID, just like any other member in the community, if they're confirmed COVID, they need to follow our isolation guidelines until they're quote cleared by public health, which is based on the resolution of symptoms. So it's that 7 days after illness onset, or 72 hours after resolution of fever. That criteria that I referenced before would clear someone for release of isolation in the community setting. For healthcare workers, we're asking them to add an additional 7 days at the end of that, if possible, just because of their close contacts, their interaction with vulnerable patients, things like this. So it would be guided by our public health, you know, guidance for release from isolation in the community, then an additional 7 days. There have been a few exceptions where they may return to work after they're simply released from isolation if a facility is facing a critical staffing shortage. But there are certain criteria they need to meet, like they need to wear a face mask and not care for particularly immunocompromised people. Things like this, a few additional hoops we have to jump through to get a healthcare worker back prior to that.
And we would work very closely with any facility that needs that help, that guidance. As soon as we're aware that, by the way, that a case is any kind of healthcare worker, that person, that situation is assigned directly to Katie's team to follow and to reach out directly to the facility to make sure that, you know, we make sure the facility is okay in terms of any issues in the workplace. We make sure the person is okay. We make sure that to address the issues around return to work, as Katie just outlined. One last thing I'll leave you with on the return to work, because I know this has been discussed in many places, here included in the state of Hawaii, but I'll say across the nation, and literally just on a call this morning with other state epidemiologists and the subject matter experts at CDC discussing this whole question of serology, antibody testing, and using that for return to work. And right from the horse's mouth from CDC, they basically said that number one, there are a lot of fly-by-night, that was their term, fly-by-night serology tests coming out, a gazillion of them really. And they're trying to check up on each one they hear about or is brought to their attention. And to date, they're seeing very few that seem to be coming from legitimate companies. So that's number one. Number two is that there are already papers, studies that are showing that there can be variability in the antibody level among persons, from person to person, in terms of, after you've recovered. And so what does that mean in terms of translating to, detectable antibody, especially for a quote unquote rapid test, serological tests, and jury is out on that. It also, if you might think about it, then extends to what does it mean in terms of immunity, and no one knows at this point. That is a big question. It is not clear. There's a lot of people guessing that after you've had the disease, you must be immune. But we know with common coronaviruses that you may have immunity for a short-term period, but that within a year or so, sometimes sooner, sometimes a little later, you lose that immunity, and that's common coronaviruses. So the question begs then, with this coronavirus, do you gain any kind of immunity after the infection? Is it effective? For how long is it effective? So still, basically what I'm trying to outline for you is that there are a lot of questions left. We're all very cognizant of this desire to have some means to sort of assure people of their immunity, but I think that's still very much unanswered. And the question about vaccine, I think that was a previous question that I'm sorry I forgot to answer that one. In terms of vaccine, think about the fact that when we've talked about pandemics, we've usually talked about flu pandemic. And with flu, we have a backbone vaccine structure. So it's not as challenging to develop very quickly a flu vaccine for a pandemic situation, and a flu vaccine that can be fairly effective, such as in 2009. The problem here is we have no backbone for a coronavirus vaccine. There's never been one. And then add to that what we already know about common coronaviruses. So I'm not trying to paint a bleak picture of the vaccine picture for coronaviruses, but I'm trying to paint a realistic one, in that we're not going to see a vaccine in the near future. If that vaccine does develop, it's going to be farther down, and there need to be studies. We don't know. It could be that it's going to be a vaccine similar to what we see with flu, where it needs to be given every year. So in the end, a lot of questions, but I'm just wanting to share with you what I've been learning, what is being discussed nationally, and all these things I'm sure you recognize impact then how we act here in the state. Again, goes back to universal precautions. I can't, stress enough, and we can't actually avoid it. I mean, that's the name of the game here. I'll end there. Kamal, are you still there?
Yes, I'm still here. We have two last questions if you have the time for it. One is, you mentioned low threshold for testing Jerry patients, and it may be a lot of burden to decide which ones, and the facility's ability to isolate while waiting for the results, particularly since old people can present in a very atypical way with respiratory illnesses.
Yeah, I would say, the testing landscape is changing rapidly. So through your routes for clinical lab testing, there may be more availability. I'm not exactly privy to their testing supplies, but there may not be, I guess just pay attention. The testing landscape is changing rapidly. So you may not have to make these hard decisions if there's availability through the clinical or commercial routes. Not every test has to go through the state public health lab, obviously. And of course, we understand that there's a spectrum of our facilities and the ability to isolate a patient while waiting for the result. Yeah, it's really tough. Some facilities are better able to do it than others. Do your best. Not all facilities even have private rooms to put residents in. We understand that, and that's why we kind of try and give these recommendations. But your facility best, your patient population best, your infrastructure, your staffing situations. So adhere to the guidance as much as you can, but also make the decisions that are best for your facility and your patient population.
The last question is, what is the state of the Abbott rapid test under an hour, the capacity in our state?
Yeah, so the Abbott test, the ID Now test, our state lab has acquired through HHS. So HHS, the Department of Health and Human Services, the U.S. Department of Health and Human Services, is titrating the machines and the test kits. So all public health labs must order through HHS. You can't even order from the company itself. And so we have been gifted, I suppose, these Abbott ID machines. They're these small units. They are, despite what's been advertised, what we've learned is they are really not point of care tests. They can't actually sit out on a desk or a counter safely. They have to be used in a biosafety cabinet. The reason being is that when you load up the sample, it actually requires that the specimen is sort of pipetted up and down in a micropipette quite vigorously before as it's loaded in. And as you might imagine, just from my description, that has potential for aerosolization. So it is not a good idea to have it out on a bench top. It needs to be in a biosafety cabinet. So that's one thing that we learned that was a bit of a downer. Second thing is that, as we kind of been saying, I've been telling other folks, because as I learned about it, I'm like, okay, well, you know, the lab tests that are done in our clinical labs, the state lab, think about them as like a 20-cup coffee pot. You know, they can put out a lot if you get it going, and they put out a lot. Unfortunately, these Abbott ID now are more like a Keurig. So it's a 1-cup deal, so one at a time. So that's also a bit of a downer. But that said, what we've thought about using these as is more like a stat lab. So if we can place them in critical areas, then we can potentially have, you know, in a hospital lab that's identified through the clinical labs and the district health offices for the neighbor islands and partnerships here on Oahu, we could maybe potentially put these in a hospital lab where if there was a critical need to know because someone is severely ill, they're in this high-risk group, the decision on medical management might change depending upon knowing what the result is, or you have a healthcare worker who has worked in a very critical area and you need to know the answers to that test sooner than later. You know, then that's something that where the stat lab might be useful. So how many machines do we have? We were gifted with 15, and then we were given 5 test kits, and each test kit can only run 24 tests. So a total of 120, is that right? Something like that. Tests per week is what we're being told if we order 5 kits each week. Now, the rumor through the grapevine is that we can actually order more than 5 test kits per week, and we're actually trying to push that right now, but we haven't heard back. We're actually in discussions right now how to best distribute these, but that is the basic idea of where we hope to best utilize these tests. We're getting to the bottom of the hour. I think I just wanted to, before we go, I would be neglectful in not letting you all know that if you're not aware, I have a deputy state epidemiologist now. Her name is also Sarah, but it's Dr. Sarah Kimball, and she is also an infectious disease specialist. She has also in her past worked for the CDC as an epidemic intelligence officer, and she has most recently come to us in the past year previously from the Chicago Department of Public Health. And so vast amount of experience from a larger jurisdiction and is well connected with her colleagues still there. Hence, I think you can safely say why it was easy for us to borrow from them for our recent transfer protocol. But you may hear from her. She is the direct support for Katie, because I think you'll all recognize that I am being pulled in multiple directions. But I also wanted to reassure you that there is a clinician support for Katie for those when she encounters questions that really do require clinician input. So I just wanted to mention that before, as I see we're getting to the bottom, and I'm getting poked that I need to go to the next meeting.
Sarah and Katie, there are a couple of questions, but I'll have people follow up with Katie by email.
Yes, please.
Your information. I think this just shows how interested people are in this topic, and I wanted to thank both of you for an excellent presentation and for a very productive question and answer session. So thank you very much, everyone.
Thank you.
Thank you.
Thank you.